Okay, so let us start our Health Literacy Explained webinar. Thank you everyone for joining. It's wonderful to have you with us for the first of a series of 6 webinars that we'll be doing over the next year that will delve into different topics and different areas important for rare disease patient groups. As we start, I'd like to thank our sponsor, Camradis, who have sponsored the webinar series. They've very generously given a grant towards this. So as we start, I'd just like to do a quick poll with everyone listening to see what your background is, what has brought you to this webinar. So let's just put up that poll. Okay, a couple of more seconds to fill it out. I will close it in 5, 4, 3, 2, 1. So it seems we've got a great diverse group with us. We've got 24% people living with rare diseases, 65% patient group or charity representatives, 18% researcher academics, 18% biotech and pharma representatives. It's wonderful to have you all with us and to have such a diverse audience. So let's get started with the webinar. Just a brief overview of what we're going to be doing today. We are going to be having a talk from Jill Rowlands about the importance of health literacy. Then we're going to hand over to Claire Murray about how you develop health literacy materials. And then we're going to have a nice Q&A where you can ask your questions and we can delve a bit more into the topic. So just to introduce our 2 speakers, we have Jill Rowlands, who is the general practitioner and professor in the Institute of Health, and in both the UK and in Denmark. And we've got Claire Murray, who is the joint head of operations at the Patient Information Forum. So without any further ado, I'm going to hand over to Jill to get her presentation started.
Good morning, everybody. It's very exciting to be here, and thank you very much for inviting me. So, in this presentation, I'm going to talk about what health literacy is and why I think it's important, the size of the problem. And then I'm going to move on to some thoughts from me about why health literacy is important in rare conditions. But I'm very much aware that this is something that that you, as the audience, will know far more about than me. And I'd be very interested to hear about what comes up in our later discussion. And then there are just a couple of conclusion slides. So, one of the issues in health literacy is that we do operate with multiple definitions, multiple views of health literacy, which in a way is quite difficult and confusing. In another way, it's very useful because we can adopt whichever definition we feel fits us best. This is the one that I like. And the reason I like it is that it puts people, citizens, communities at the center of health and being able to get hold of, understand and use information to health. And obviously the rare conditions community is one with very particular health literacy issues. So it's a group for whom I think health literacy is very important. So you'll all have access to these slides afterwards. And I just thought it was helpful to think about the different aspects of health literacy, and we can think a bit later about how that might apply within the rare conditions field. So functional skills are really about the Thank you. I'm back. It's about the very basic skills to be able to read, to be able to count. Then you have the communicative, interactive skills, which are really about having the language and confidence to be able to talk about health with your peers, with your family, with your general practitioner, with your nurse, with your specialist. Critical skills are really those skills to evaluate the information, see its relevance to you and your family and your community, identify whether there are any issues, any barriers, and have the skills to be able to overcome them. Public health literacy is interesting. It's really bringing in the skills to evaluate the importance to the wider community and recognise that that may sometimes be in conflict with individual needs. And then distributed health literacy skills, I think, are very interesting and important for the rare conditions community, because it's about having a network and having skills within that network and being able to both contribute to the network but also draw on the network when needed for additional health literacy skills. So a bit more about whether or not health literacy is important. So I and some colleagues undertook a study which was published last year. And what we did was we collected some health information materials in common circulation. And then we looked to rate them for their literacy and numeracy difficulty. And what we were looking at was the level of literacy and numeracy skills people would need in order to be able to fully understand and use them. And we set a competency threshold. And we said that people who could understand and use 70% or more of the materials had reached that competency threshold. Pardon me. We then went back to the National Skills Survey and looked to see what proportion of the population reached that competency threshold. Just so you can see what these thresholds are. What you can see, this is looking at the literacy, the text difficulty. You can see that actually a lot of material was written at level 2, which is 14 to 16 years level, whereas actually the population, the median skills level was actually lower than that. And then if you look at numeracy, we found that the numeracy content of the material was at a simpler level than the text. It was at the 11 to 14 years. The problem is that the median population level for skills is at entry level 3, which is the 9 to 11 year level. So we're starting to get a feeling here that there's a mismatch going on. And what we then looked at was the variability across the country. So we found that some material only had text in it, and 43% of the population, if you look at the country as a whole, were below the competency threshold. So that means they wouldn't be able to fully understand and use the materials unaided. Doesn't mean they'd get nothing from it, and of course it doesn't mean that they couldn't go and ask someone about it, but they didn't have the skills to do it on their own. The other thing to pull out of this is that there is regional variation. So you'll see that, as with a lot of these things, you have the relatively affluent south, where there are fewer problems, the less affluent north, where there are more problems, and London as an island of deprivation in the southeast. And that's quite a common picture for this sort of thing. We then found that if you bring in the issues of numeracy, if you have health information that has numeracy elements, the proportion of the population who can't fully understand and use it without help jumps up to 61%. Again, we have this regional variation, and you can see that in the areas where there is the highest proportion of people facing these difficulties, like London, like the Northeast, you're looking at 2/3 of people. So it does affect a lot of people. The other thing, just to bring in, is that within people's skills, people have what are called spiky profiles. Um, and that means that people are going to have higher skills in some areas than others. That's true for everybody. We all have ways that we prefer to learn. But for people at lower skills levels, the profile becomes more uneven, and we really have to tailor information to people's preferred learning styles. And we have to think about the impact of illness, stress, distress. And of course, that's of great importance when people are facing up to the huge issues that come with either living with or having a family member with a rare condition. And there are also other important things to consider, like culture, language, ethnicities. And so there is something to be considered about building a range of health literacy resources within communities and social networks, rather than always trying to build skills at an individual level. So thinking about health literacy then and rare conditions, and as I said, this is something you're much more expert in than me, so I'd be really interested to hear your thoughts. But this is a general practitioner's view of rare conditions, and I thought back to those families that I've worked with and supported and treated who were facing the issues brought through rare conditions. The first is that the information, the written information, is very complex. So conditions are often complicated, affect multiple body systems. So the information is firstly very difficult to write. I don't think we should beat ourselves up too much about the fact that health information is written at a complex level. It is very, very difficult to talk about complex medical conditions in very simple terms. But it does make it very, very difficult then for people to understand the information they're given. The other issue, and if you think back to what I was saying about numeracy skills being low within the population, and the fact that when you have numeracy issues in information, it becomes much more difficult for people to understand. This is important for the rare conditions field because the numbers are complicated. So as we all know, a rare disease by definition is something that affects less than 5 in 10,000 of the population. Having said that, there are so many rare conditions that 1 in 17 of us are going to be affected by it at some point in our lives. So any one condition is rare, but if you look at us as a community, there are lots of us. Rare conditions vary between something that can only affect one person, maybe in a country, and with the more common rare conditions, then you have a large community in each country. Many rare conditions, not all of them, of course, but many of them are genetic. So suddenly you jump from having a very low chance of something to finding out that actually every child that other child you have maybe has a 50% chance for an autosomal dominant condition, or a 25% chance if it's an autosomal recessive condition, and then you have issues like variable penetrance, etc. So it's all very complicated. Going back to the spiky profiles slide, time of diagnosis enormously stressful. So any skills and capacities that families and individuals have will be stretched to the limit. I know from experience that GPs will know little or nothing about the condition, and very, very quickly my patients will far outstrip me in their knowledge, and that's fine. But at the beginning, that's really tough because you expect the GP to be able to give you, share some knowledge and support, and you suddenly find that the GP is fine with the support, but the knowledge isn't there. Also, people are very isolated. They're rare. You don't know anybody else who's going through this. And then there are the practical issues, such as having to go very long distances to specialist appointments. Now, in my last practice, I was working in London, and one of the beauties of London is that we have a range of specialist hospitals, but other people in the country can have to travel the length of the country to see their specialist, and all the issues that brings with it. Okay, so I hope I have explained why I think that health literacy is not only interesting, but also important for us all as patients and users of the health service, but also maybe there are some very specific issues within health literacy for people within the rare conditions field. So here are some thoughts about what we could do about it. And again, let's pick up on this in the discussion and see what you think of these as some ideas. I think we should look at developing a centralised resource of information that we know is high quality and can trust. I know from experience how difficult it is to write this information. Often it's better to actually fund an expert in writing at simple levels to actually do this for us. I was very interested to find when I started work in this field that those journalists that I thought had the simple job because they were writing for those newspapers where the readers tended to have lower literacy and numeracy skills, like the Daily Mirror, the Sun, etc., etc. And I thought the complicated stuff was writing for the Times and the Guardian. In fact, the reverse is true. The real skills lie in terms of this area with those people who are able to write take complex concepts and write them so that people with lower skills levels can understand. So it's a specialised job. If we're going to do this, think about how we fund this. But if we were to do this, people have a go-to place. They know the information is going to be high quality. Information can be developed in a variety of formats to fit people's preferred learning styles, pictures, videos, audio clips, written materials, and people can dip in and out of the resource and use it when they need it. The other key thing is to make sure that people who are living with these conditions are involved in the development of the materials, because they know what it's like on an everyday basis. They know what's important, what should be emphasised. So that's one side of it. That's about making the information better. This is the other side of it, which is about building health literacy skills. Now, I'm a teacher, so I'm very in favour of anything that builds skills at an individual or a family level, and I'm certainly not saying that we shouldn't do that. And in particular, there's building skills and language around the basic functional level. So just having heard and understood the words that start flying around when you see the specialists. The skills and the language then to be able to discuss it with people, with your family, with your friends. How do you explain to your friends what's going on? How do you seek their advice? How do you talk to the doctors and nurses about it? What do you do about it? Building those critical skills to identify the barriers to moving forward and giving people the skills to overcome those barriers. And then I think the issue of sharing skills through virtual networks has huge potential for people living with these conditions and people working in the field. Let's look at building networks and sharing skills, building distributed health literacy skills so that people don't have to do it all themselves. They have other people that they can call on to help, and also they'll be able to contribute to those skills themselves. And I think I found this on the Find a Cure website, and I think this says it all. It's about empowering patients and patient groups to become effective campaigners for change. And I think if we make sure that patients and families and communities are at the centre of everything here, that's going to keep us focused and in the right direction. So just to pull this all together, I hope I have made the case that low health literacy skills are a problem for all of us across the whole population, but the people and families living with rare conditions face particular challenges due to the complexity of the condition, the complexity of the number involved, and also the isolation that comes with this. And I think from a health literacy perspective, we can do a lot through developing and sharing good quality, accessible materials, supporting patients and families to develop and share skills, and there may be other things that come out of our discussion today. So I'll stop talking at this point, and we can then just throw this open for discussion, for you to send some comments and thoughts through to Flora. What we're going to do initially is those questions that are around clarification in relation to this presentation we'll deal with now, and then I think the wider discussion points maybe we'll pick up in a more general discussion at the end. So over to you guys. Thank you very much for your attention.
Thank you very much, Jill. So I've just got the chat open, and I welcome anyone who has any questions to just type them now into the chat section and let us know, and we'll have Jill answer your questions. So are there any points for clarification? Okay, while we wait for any questions to come through, Jill, I was wondering, from my perception of what would you say is the first step to analyze the information people already have? And I wonder whether Claire will pick this up in her presentation as well. But from your perspective, what is the first thing to do when you're thinking about the material you've already got?
Well, there are programs, particularly for text, that you can actually, particularly if it's material you've produced yourself and you have a Word version of it, you can cut and paste and put it into these. There's something called a SMOG calculator, which is the simplified measure of gobbledygook, which was developed in the US, but NIAS, which is the National Institute of Adult Continuing Education, have produced a UK English version. So you can just stick that in and it shows you what reading age it comes out at. And then you can play with it and try and get the difficulty level down. There are some very simple steps that one can take, like making sentences shorter, keeping the number of words which have more than 3 or more syllables to an absolute minimum. And then there are other things like layout, spacing, etc., making sure there's plenty of white space, the text is large enough, use of bullet points, those sorts of things. So there are there's the sort of reading age side, which is the SMOG, which is, I think, it's not a perfect tool, but it's a useful one and very easy to use. And then there are other issues in terms of layout. Numeracy, it's more difficult. There isn't a SMOG equivalent for numeracy, but there are some very basic guidelines. And again, I'd be very happy to to share that with people afterwards, which are looking at things like using small numbers wherever possible, avoiding fractions, avoiding people having to do calculations as they go
Yeah,
through the material. So there's those sorts of things.
it's
But having
brilliant.
said all of that, just take what I've said and think about trying to do that for a complex condition, and it's a really difficult ask. So
Yeah.
I would very much say everybody will have spent a very long time developing your materials. Let's not beat ourselves up about them being too complicated, because it's the nature of the beast. But I do think we can help each other to make stuff better.
Great, and I'm sure Claire will pick up in a few minutes about how to actually go about the process. We've got some great questions through. Um, Firstly, we've just got a comment from Alan saying that he completely agrees with you, Jill, about how complicated this issue is.
Yeah, good.
Um, and let's pick up, there are several that would be good to pick up at the end. But for now, I'll just take one question from Libby, which is, for complicated rare diseases that affect children, is it worth trying to develop materials for the children themselves to understand? Could we ever make it simple enough? Can you recommend anything?
Okay. Yes, is the answer. I think that's really, really important, because it's important that it's the person, the patient themselves, who's in as much control of the facts as they are able to be. And I would, for instance, let's go to our colleagues in the cancer field, a lot of whom are actually dealing with rare conditions, leukemias, bone cancers, those sorts of terrible things. And they are real experts at writing material for children, and furthermore involving children in writing the materials, and recognizing that that involvement is bound to be different for very little children, from, for instance, 12-year-olds through to teenagers. So talking about distributed health literacy skills, there's a lot of expertise, for instance, in that field. So I think we should go to them for some advice and support.
Great. Well, thank you, Jill. I think we've got time for another quick question. I think there's a comment here saying, I think health literacy isn't just about literacy per se. I think it's about using technical language and having terms explained. And that's from Carol, and she suggested that everyone look at the UPatty online toolbox, which I believe
Mm-hmm.
goes into quite a lot of detail
Mm-hmm.
around research and different
Yeah.
medical terms.
Yeah, and I thank you for that comment. And I think it's essential. We can't get around the fact that we're going to have to talk about medical conditions and use medical terms, even though that's going to make our information more difficult to understand, um, because we need to support people with these conditions and their families to develop also the language and the confidence to discuss things. So if you go and see your specialist, they are going to talk technical. And if one doesn't have that language and skills, immediately one's at a disadvantage. So we have to address that too, and we have to include it in what we're learning.
Great, and I've just seen a comment from Claire as well, which is an excellent lead into Claire's presentation, saying that PIF have actually developed a guide to developing health information for children and young people that's available on their website. So I think actually with that point, I will thank Jill from the behalf of everyone listening for your
You're
wonderful
very welcome.
presentation,
You're
and
wonderful.
I will I'll hand over to Claire.
Hello.
Welcome, Claire.
Thank you very much, everybody. My presentation up. Yeah, thank you very much to Flora and Find a Cure for inviting me to talk today, and for Jill for a really interesting overview of health literacy and sort of thinking about how it can impact specifically people with rare conditions. So what I'm going to pick up on today really is a practical look at the key principles to creating health information that will support health literacy, i.e. how we can develop health information that is clear and accessible to its users and supports them to be involved in their health and care. But I think, as Jill sort of has said, it's not an easy thing. There's a real skill involved in doing it. But there are some from research and evaluation out there, there are some best practice principles that exist. So I'm hoping that I can share some of those with you today, and that you'll we can talk about them later on. So I'm going to first of all talk about how we define health information support at PIF, the impact of good quality health information and the reality for patients today, and then you'll sort of move on to looking at the best practice about how you can create health information that works. So I have been at PIF for about 3 years, and just a bit about my background. Before then, I worked for NAM, the HIV information charity, for about 10 years. So I've been involved in this whole sort of area of health information for a little while. Just a little bit about PIF, so you know where we're coming from. So we were formed 20 years ago as a non-profit organisation, and our vision is a society where everyone has access to high quality health information and support that enables them to make informed decisions about their health and care. So we're a network of people across the UK who produce and provide health information. We've got about 550 members and 2,000 more people who follow and engage in our work in other ways. We bring people together from across the voluntary sector, from NHS organisations and public health teams, and also sort of commercial companies and independent providers as well. And we sort of firmly believe that clear, accessible, reliable information developed in partnership with patients is a basis of person-centred care and shared decision-making, as well as supporting greater self-management and self-care. So we publish best practice guidance and practical resources. We hold seminars and conferences. And our membership network means that hopefully people working in this field can connect with each other to share their projects, challenges, and experiences, and hopefully to find solutions. So when we talk about patient or health information, so we worked quite a broad definition, and for us, information is a factual tool that increases a person's knowledge and understanding about their health, treatment, and care. It is also the basis upon which partnerships between people and healthcare professionals can be created, and care can be personalised and coordinated, and a person supported to sort of really play an active role. The channels of delivery of health information are many and varied. So we're talking about printed leaflets and booklets, digital media such as websites, apps, videos, online communities, patient education programmes, decision aids, social media, health records, appointment letters, signage, informed consent. All of these things have an element of sort of health information within them. Picked up on the importance of information being supported, and sort of recognising and enabling that is a key part of our work. So support really is a vital partner of health information. Support makes sure that information is understood in the context of an individual's specific situation in life, and support empowers people to use information to make decisions about and play an active role in their health and care. So just as a quick example, the graph on the slide is taken from a report we did last year, where we spoke to 2,000 people living with long-term conditions. And we asked what would help them feel more in control of their health. And the top 2 choices were around being given more time to talk about their condition. So it wasn't so much about the fact they needed to be given more information, but they wanted to be given more opportunity to talk about the information they had. So why do we think health information is important? What sort of outcomes can it affect? In 2013, we carried out a review and published a report setting out the evidence of the benefits of providing and the harms of not providing high quality health information for patients and the public. So the report really aimed to create a business case that would support those working in the field to improve the standard of health information and integrate it into the wider delivery of services. And the evidence that we sort of looked at found that improving access to health information increases patients' knowledge and understanding, impacts upon their behaviour and enhances their experiences of care. It was also found to be key to unlocking patient engagement in their care. The evidence demonstrates a clear link between these factors and improved outcomes for patients, as you can see on the slide here. Increased treatment in line with patient preferences, better adherence to treatment, greater health literacy, and improved quality of life and well-being. The report also found that the use of services and the sort of costs associated with healthcare were also positively impacted by providing high-quality health information. So that's the ideal, the sort of potential benefits that could be seen as a result of health information. But what is the reality for many people today in terms of how informed they feel, and how easy is it for people to access the health information they need at the right time and the right place for them? So we sort of, Jill's really obviously touched on looking at it from that sort of health literacy point of view. And there are statistics at a national level which provide a snapshot. But I'd be really interested later on to hear about your experiences and what you think about how, what people's experiences are of being provided with or able to access the information they need. So anyway, the statistics provide a mixed picture with some definite areas for improvement. So the 2015 CQC Adult Inpatient Survey found that 84% of those who had an operational procedure whilst in hospital said they received a complete explanation about the risks and benefits in a way they could understand, which is great for the 84%, but that does leave 16% who didn't receive that in a way they understood. Another example comes from the report I was talking about that we conducted, the survey we conducted with the 2,000 people living with long-term conditions. So 20% of the people we spoke to said that today they did not feel they had enough information to be confident in discussing treatment decisions with their doctor. And 36% of them said that when they were first diagnosed, they weren't given helpful information about their condition. The CQC survey as well also gives specific examples of groups who might typically have lower levels of health literacy, are often less well catered for. So with responders with a learning disability or a mental health condition, the percentage who said they received a complete explanation about risks and benefits in a way they can understand was lower, only around 75% compared to 84% of overall. In order to achieve the benefits outlined before and to deliver to patients the support they're looking for, it's not just good enough to provide any old health information. It does need to be high quality in order to be effective. So research and evaluation has identified this means information needs to meet the needs of its users, empower them to make choices and take control, be tailored to reflect the individual's needs and circumstances. So this includes their health literacy, their point on the patient journey, their preferences and their communication needs. It needs to be developed with users, be accurate and evidence-based, and then be embedded within care pathways, be clearly communicated, be supported in its delivery by communication that converts it into understanding, and sort of be delivered within a wider environment of education and support. So whilst quality is clearly about the information resource itself, equally as important is the way in which it is provided and how it is integrated into wider treatment and care. The evidence really sort of highlighted the importance of healthcare staff, but other professionals and organisations that support patients or clients acting as an intermediary for information and signposting them towards high quality health information and helping them understand how the information relates to them. It was also found that evaluating the impact of information was really important. So obviously it's only through understanding the difference that information makes we can understand more about what works and continue to improve the quality we offer. And also through evaluation we can really strengthen the case for information, which is vital if we're to convince policymakers, commissioners or those working on the front line delivering services of the immense value patient information has or could have. To support more organisations to produce health information that delivers on these quality measures and create health information that responds to and supports health literacy, in 2015 we developed a series of best practice guidance which we shared as an online free to access toolkit. So firstly we wanted to look at the evidence behind what made health information effective. We conducted a literature review and sort of identified the key components, and these really sort of fell into 4 areas. So ensuring information is accurate and reliable, that it's clearly communicated, that it has impact and is effective, and that it's developed with its users. We worked with the PIF network to turn this evidence into best practice and key steps that could be used to guide anyone seeking to create or provide health information. I'm not going to go into detail of all the steps, but in the next slides I've tried to highlight some of the ones that most directly relate to creating health literate information, though you could say that all of them are an important part of that, really. The first thing to focus on is involving users, and this really is an underlining theme across the whole of best practice. So making sure that information is developed with users is the only real way to be sure that your information meets their needs and will be understood and can be used by them. But what does it mean to properly involve users? So for us, it means involving them all the way through the process, right from the planning stage, through to the thinking about what format you're going to deliver it in, how you're going to make sure it reaches people, what the content's going to be, how the layout's going to be. We don't believe that user involvement is just having a peer review panel sort of rubber stamp a product at the end of its development cycle. And the other thing that's really key here as well is working with a representative sample of real users. And this is something that can be really, really hard because, understandably, the users that are most keen to volunteer or be involved in information development, those that are already engaged in their organisation, and so most likely to be relatively motivated, health literate and informed. So how do you find those potential users who aren't using it yet to check that whatever product or service you're developing will meet their needs? So through our research, we found that it's really important to go to where these people are already. So don't expect them to come to you, and also to design an engagement process that suits them. One approach to this is identifying and connecting with other groups or organisations that might already be linking in with those communities you want to work with, and reaching out through their already established networks and learning from them what engagement methods work. So for example, when I worked at NAM, the HIV Information Charity, I was involved in a project to create some basic level information resources that would help people with HIV who had low level knowledge and motivation, so people with low health literacy, to increase their understanding of some of the key health messages that support people to live well with HIV. We knew from talking to clinics and support groups and from testing and outcomes data that a greater number of African people living in the UK with HIV fell into this category. This is one of the main communities we wanted to work with, but we also knew that our current sort of reach in those communities, wasn't good. It was really poor. So we reached out to African community groups to host a series of events, based within the communities, for example, in churches and community centres. And we used their understanding of people to inform the design of the events. So we made sure food and a creche was provided to support the family element that they told us was really important. We held them at times and locations that were convenient to the users. And we also had the community groups lead the conversation, so the participants felt more comfortable talking about what is an issue that's got lots of stigma attached, especially with African communities. So the approach worked really well, and we built up really good relationships, and we were then able to go back to those groups as our resources developed to test out our designs and how well people understood the messages involved in them. Another example that provides quite a good illustration of a resource that has responded to an identified need from a specific audience group, and really illustrates how that audience was involved throughout the developing resource. It's shared on the PIF toolkit, and it's from Bowel Cancer UK. So the resource that was ultimately developed was a guide for people under 50 who have been diagnosed with bowel cancer. And the original concept for the guide came from user research, a campaign titled Never Too Young, which found, amongst other things, that 41% of the younger people that were spoken to were mostly offered information targeted at older people. So Bowel Cancer UK surveyed and interviewed a small group of people who have been diagnosed with bowel cancer under the age of 50. And they asked them about their experiences of accessing information and what they would want from a new resource. So most people they spoke to said they didn't get all of the information they wanted when they were diagnosed. They didn't like the images of older people in the existing resources. And they wanted information that was specific to bowel cancer rather than cancer in general. So some people didn't want too much detail to start with, but they wanted to know what information was available and how to get it. And the most popular format was a printed booklet or a leaflet. This feedback was used together with the results of the Never Too Young campaign to develop a concept for a booklet that was reviewed by 12 potential users. So these users were involved in sort of commenting on the initial plan for the content as well as the first and final draft. And they also were involved in talking about deciding how the booklet should be disseminated. And this engagement process led Bowel Cancer UK to develop a printed booklet that was to be handed to people at the point of diagnosis by their health professional. The content would focus on topics that younger people find it hard to get information on, such as fertility, genetic risk, the impact on young children, family and work life. And the rest of the booklet would introduce other topics such as treatment options, but would signpost to other resources for more detail. That's another example, really. Ensuring health information has impact and relevance to your users is another vital part of creating health information that's effective and supports health literacy. And at the basis of this really is understanding who you are creating your information resources for. So the type of health information that is most appropriate and impactful will be influenced by the characteristics of your target audience. So their gender, ethnicity, age disability or communication needs, so sexuality, lifestyle, location and health literacy. The range of sources you can use to research characteristics of your audience. You can talk to them themselves. You can use feedback from health and care professionals or community or voluntary organisations that work with the groups you're trying to reach. And there are also bigger sources of data such as health data and social research projects. Every individual will have different information needs, and the most effective information, which sort of Jill referenced before as well, is that which is tailored to specific needs and circumstances of each user. So patients vary widely in their individual characteristics, and really there can be no one-size-fits-all approach to providing information. So while resource constraints will obviously limit the extent to which we can produce personalised health information, there are clear benefits of doing so. A National Voices review found the single most important thing to increase the impact of health information is to tailor it to the individual user. So decision aids are a growing approach to providing health information based on this principle of tailoring information. They ask users a series of questions and then tailor the information that they give based on those responses. But there are also more low-tech approaches. So the MS Trust had a project called Making Sense of MS, and they developed information in a series of fact sheets, and then the users themselves would choose which fact sheets, so which areas of information they were interested in, and create their own tailored pack of information support rather than the MS Society producing a whole book, making assumptions about what it was people wanted to know, what they were interested in. Having a clear objective or purpose to your information resource is a really important part of creating information that enables users to act. And user testing health information to ensure its key messages are understood, especially by audiences with lower health literacy, is crucial to a health literate approach. So a practical example of how this has been approached has been documented as part of a study on the National Bowel Cancer Screening Programme. So this study assessed how well the screening programme leaflet was understood by study participants, and it used a comprehension test with 8 true or false statements that participants in the trial were asked to answer after they'd read the leaflet. So that's one example of how you can use a test how much a person has understood from the information that you've given. There's also a method called Think Aloud, where participants read or watch a health information resource, and they're asked to verbalise their thoughts throughout that process. And again, recording these thoughts gives those developing the information resource an understanding of how a person is actually interacting with the content that they're presenting. Another area our best practice highlights is that the about who or how you're going to support patients to understand and use your health information. As we heard earlier on from Jill, information has a greater impact when it's reinforced by verbal information from healthcare professionals or from other organisations and sources of support. And the International Criteria for Decision Aids states that information producers should plan how information will be integrated into clinical care. So it's really important that information producers work with healthcare professionals or others, such as self-help and support groups, to really think about how that information material will be delivered and how it's going to be supported in order for people to make use of it and understand it. Moving on to think about different sorts of content, feedback highlights that users really value other people's descriptions of their experiences, and patient testimonials can help make health information materials more memorable, realistic and comprehensible. However, it's really important to recognise that personal stories have been found to affect patient values and choices differently from the way facts and statistical information affects them. So balance needs to be achieved between those two different types of content. When we looked at the ways people had tried to address that, including voices with a range of perspectives and experiences within health information, and or explaining the rationale for including particular examples, along with making a clear distinction between factual content and experiential content, were the best practice recommendations to help achieve that balance, really. So ensuring the format of your health information is accessible and acceptable to your users is a vital element of making sure it reaches and can be used by them. And using visual and audio approaches can be especially helpful for people with lower health literacy. For example, using video or infographics or using images to represent key content. As on the screen now, there's an example from Breast Cancer Now, who developed a great visual approach to explaining risk factors associated with the disease. And this particular slide is looking at statistics relating to breast cancer screening. However, I guess it's just important to flag up really that inappropriate pictures, tables and graphs can cause confusion and send out the wrong messages. So in the same way you would test written or spoken content, visual representations should also be tested to ensure they actually explain or add to the content. from NAM, the resource I mentioned earlier, which evolved into a visual series of fact sheets where images are used to sort of convey key health messages. And sort of, I guess the final area I'm really going to touch on is ensuring clear communication, which is obviously key to developing health literate health information. And the toolkit looks at how to ensure health information clearly communicates its messages. Areas, so keeping language clear and simple, breaking complex information down, using layout and design to help users navigate your information, and ensuring you meet the specific communication needs of your users. So for each of those areas on the toolkit, there are sort of key steps that can be followed, and I'm going to sort of pull out and highlight just a few of those now. And so one of the most important elements is to avoid jargon. I think we spoke about that earlier on, and to explain medical, clinical, or health service terms. Another tip is around using words your audience use in their everyday lives. So example, tablets can make you feel sleepy rather than drowsy. And also avoiding words where possible that mean things means different things in a clinical context. So, for example, the word positive, which in everyday life is a really, really good thing, but often in health, it can mean the opposite. It can mean a test result that actually isn't good. Complex words with multiple syllables, words with multiple meanings are likely to disengage people, particularly those with low levels of health literacy. As Jill referenced, that using short sentences has been really found to be useful in making content more accessible. In general, no more than 15 to 20 words. And short paragraphs as well is really, really important. And quite a good tip is to read it out loud to yourself to see if you can make it shorter or simpler in some way. Using an active tone, talking directly to the end user will make your communication more engaging. So, for example, your appointment is on rather than your appointment has been made for. And when thinking about laying information out, i.e. on a website or a printed resource, using colour and subheadings to help people navigate through the content and including a summary of key points have all been found to make resources clearer. It is recommended to avoid using italics and capital letters and to use an appropriate size print font, so at least 12 points, but often larger. It's important. Focus section on the toolkit on how to clearly communicate risk information, and I've included all the best practice steps from that on the slide. Research shows that different people interpret the verbal descriptors of risk, so terms such as rare, unusual and common, in very different ways. Evidence shows that patients have a more accurate perception of risk if the probability of an event occurring is presented as a number, i.e. 1 in 100, rather than using words such as rare and common. And using absolute risk rather than relative risk has also been found to give a more accurate understanding of risk. So, for example, saying the risk of an event increases from 1 in 100 to 2 in 100, rather than the risk of the event doubles. Percentages can be hard to understand, so best practice recommends you try to use natural numbers, i.e. 10 in 100 rather than 10%. And also how risk is described can have an enormous effect on how it is perceived. So presenting both the negative and positive framing is recommended is really important. So including both the chance of survival and the chance of death with intervention, or the chance of getting a side effect and the chance of not getting it. And then making risks relevant to your audience has been found to be really useful when supporting people to understand statistical information. So maybe using examples as this is the equivalent of one person on your street. And this links back to the point about trying to tailor and personalise information as much as possible, but also to the need to user test information. So that the example that you actually picked to make the risk relevant actually conveys what you're trying to make it convey, or is interpreted in the way you expect it to. Last sort of area on the toolkit is about ensuring information is accurate and reliable, which is obviously a key part of creating health literate information, because if it isn't, then you're not supporting people with good quality information. But I'm not going to pick up on that now, but I want to just include it here so that if it is an area that you'd like to find out more about, then you know it is there and you can look it up. Thank you very much for listening, and I'm looking forward to any sort of questions or comments you might have about our toolkit and the sort of the guidance that there is.
Brilliant. Thank you very much, Claire. We've had quite a few questions that come up, and I think some of them would be best to direct towards you, and then I'll bring Jill into more of a general discussion. So just the first question that's come up is, are there any organizations that deal specifically with simplifying complex medical information? Is that something PIF do, or do you have any recommendations?
Yeah, so there are so a number of organisations have published some really useful, I guess you'd call them thesauruses, really, but where they work from it, and they take medical words that are often used in medical language, medical speak, and they give a plain English example of them. And so what I can do is I can share the links via Flora after, and maybe we can share them out with you. But they're all available on the toolkit. So on the toolkit, there are a load of practical resources that try to help people follow the best practice that we're recommending, and some of them are produced by us, but not all, because there's so much good stuff out there. So what we try to do is bring it all together, really. So to say, there are these dictionaries that different organisations have created that you can go through and think, oh, that's how they've that's how they've simplified that.
Brilliant. And I'll actually bring Jill in now for some of the themes of questions that have come up. So Jill, can you just indicate that you're speaking and you're unmuted?
I can certainly hear you. Can you hear me?
Brilliant.
Yes.
Yes, so there are two themes that have really come up that'd be good to explore, about how specific rare diseases have different impacts on patients. So we've had two questions of, are there any advice or tips for writing good health materials for people in the deaf community, and also for people who have either neurological or cognitive impairments as a result of their conditions. So throwing that out to both of you.
Okay, so that's DEAF, DEAF, is that?
Yes.
Yeah, okay. So the answer is, from me, is that that's not information I have at my fingertips, but I am absolutely sure that there will be plenty of people out there who have developed information for those two groups. Although, particularly for the deaf community, maybe not so much for the rare conditions field. So that may be an area where actually we need to engage with groups who are used to writing information for that group, and then get them together with people who are experts in living with or supporting or treating people with rare conditions, and get them to work on something together. In the neurological field, there will be a lot. Because, for instance, conditions like Huntington's disease, for instance, that is a rare condition with a huge neurological component and cognitive decline, and also because there's a lot of information around for people with more generalized neurological decline, things like Alzheimer's disease and microvascular dementia. So I think one of my key messages is, let's not reinvent the wheel. Let's look to see where there is expertise and capacity and knowledge, and get people together to work together. And for instance, particularly in the Huntington's field, for instance, there may well be a lot of information that's already developed, that's had a lot of thought put into it, that is very good from a health literacy perspective, that can just be picked up and used. And then where there isn't, where there aren't materials, and I'm using materials in their widest sense to include audio clips and video clips and whatever, then get together with experts and develop new stuff.
And Claire, are you aware of any existing resources in this area?
We ran an event last November about accessible health information, and we had Action on Hearing Loss came to talk there, and they had some really sort of useful, interesting resources that I think and stuff that could be adapted by people in different health conditions. That might be quite an interesting place to look. We also had somebody talk about developing some resources for a group with cognitive impairment, but the exact person who it was escapes me at the moment. But we, on our website, we've got a network about accessible health information, so the idea that it brings people together that are interested in this topic. So be it creating health information for learning disabilities or sight loss, or or from the deaf community. So it's supposed to be a place where people can ask questions like this. So if you're trying to produce a resource for for people with hearing loss or cognitive impairment, you could post a question on that, and other people who've got experience in that, or who might have seen a resource, would reply, and sort of you could hopefully connect with people who've been working in that field. So I think Jill's point about not reinventing the wheel is really important, but I think we're really aware that it can be so hard to know what is out there and where you can look, and there isn't one place that brings together all the resources for different types of accessibility needs, different communities that might have communication needs, but our discussion forum, which is completely free to join, and it's got about 400 members on it, it might be a good starting point.
Okay, great. And then another question that came up was actually about developing these materials, and an attendee has asked, do either of you think it's unethical to ask drug companies to fund creating new leaflets or new health information?
So when I worked at NAM, which is it's an HIV information charity, so there were we had pharmaceutical funding, but we had a really clear editorial policy that said that that no funder, especially a pharmaceutical company, would ever have any editorial involvement in producing a resource. But also we were quite careful about not letting any single pharma company wholly produce any resource, again to try and get balance. And so there are a number of checks and balances that you can get in there, I don't think it's unethical, as long as you are sure that you've got a really transparent relationship, and that taking that funding is not having any form of impact on the content or or the development of the information at all.
It's Jill. I'll just come in and just echo, I think, a lot of the things that Claire has said. For me, it's around the quick answer to your question is no. I don't think there is a problem. I think there are things that have to be put in place. There needs to be absolute clarity, I think, is the main thing. What are the boundaries? What's the involvement? To what extent is there any editorial control, or is it very clear that there's no editorial control? So issues of clarity and governance, I think, are absolutely key. So thrashing those through, and then making sure everybody knows what's in place and what you're doing, and then I think it's absolutely fine. I don't have any problem with it at all.
The other thing that we used to do is just obviously we'd always make sure that we explained on the health information resources who'd be involved in funding it, but that they'd had no editorial involvement. So I think again that's that extra step of transparency, is making sure that you share how that with the users.
Can I just bring up another suggestion here? This isn't so much about funding to develop materials, but where such materials might be hosted. So NHS England have funded the Community Health and Learning Foundation and the UK Health Literacy Group to develop a health literacy resource area where materials can be hosted, for want of a better word. I mean, it's like putting them in a filing cabinet, and then anyone can go in and search and find stuff and just use it if they want to. So maybe in combination with looking at how we develop new materials, where we need new materials, we need some way of just making what is there accessible and useful for people, and something that's already been funded and is in place, and also because it's been funded by the NHS, we know that there aren't any issues of governance, etc. I just think would be a useful resource for everybody.
And picking up on that, Jill, actually, we had a question following your presentation, which was, could you expand on your idea of a central resource and how this might be funded? And is this a job for NHS Choices, NHS England, or Public Health England, perhaps? And that's come from Lizzie.
Okay, so yeah, so there is this resource which has been funded by NHS England, and I think we should look to see how we can best use that resource. I think the main issue in terms of cost is actually the development of the materials, and I think other things like how it's made available, checking that you know how recently it was developed, and you know when the next revision of it is due, etc. Those can be very easily put in place, and then yeah, that resource is there, so we should use it.
Right, and following up on that, just a quick extra question that we've gotten is, can anyone deposit their information into that health literacy resource?
Uh, yes, but there is a system whereby people tell us about the resource, and then we go through a process of working out where it would best go and those sorts of things. Beg your pardon. So people can't just upload their stuff. They can tell us about the resource that's available, and then we will work with them where it is best housed and on the site and how people find it, etc. So there is a process to do that.
I think in terms of from a sort of patient or a person perspective, the original question asked about NHS Choices, and I do think that's got an amazingly strong brand, and it is often a go-to place for people to turn to. So I think something PIF would like to see NHS Choices do more of is linking out to you know, patient groups and other organisations that have developed really useful information resources, and maybe acting as that sort of that signposting role.
Yeah, I think that's a very good idea. And just to come back to that, there's no reason why in one of these sites you couldn't have a link through to other sites so that people wouldn't have to go and search in multiple areas. I think one of the challenges for us in terms of a community who want to make health literate information available, one of our tasks should be to talk with each other, and when there's something good on one website, we make sure that people can find it on our website and follow a link through, because otherwise people will spend all day searching different sites. So I think if we should be smart enough to be able to avoid that, and to build on the strengths that are already there.
And coming up on that point of NHS, we had a question from Alan, which was around, I think, building on his question that it's all well and good for us to produce good health information, but a lot of the NHS health and medical community is full of hard to decipher language. And what is there that we could do to try and make that more accessible?
Shall I kick off with this? So NHS England have set up a group that is thinking about how to take health literacy forward in England and in the NHS in England, and Public Health England are also part of that group. And I would suggest this is something that should be picked up by that collaborative, and there should be some thinking at the top level so that this issue, and it is a real issue, both in terms of letters that are sent out, websites that are available, telephone answering systems, finding your way around the hospital when you turn up. There are lots of issues, and I think there needs to be a coordinated approach, and I think it's best led by NHS England and by Public Health England. And I think the collaborative is probably the engine to drive that forward. So I'm very happy to take this forward as an issue that came from this meeting. to the collaborative for us to have a think about it. And then if anyone from this group is particularly interested in taking this area forward, then you can send me an email. My email's on the presentation, and we can talk about it offline. But yes, I think we do have a duty to address this because it's a systemic problem. So rather than just addressing it in one hospital, we actually look at how it can be looked at across the NHS, and a plan developed to take it forward in a coordinated fashion.
We do work with people who work in different NHS trusts and CCGs, and I think there's some of them in some there's a real commitment and actually an investment in producing really clear information for their service users and their patients. But as Jill says, it's not across the board. I think there are a number of different projects going on to try to push that forwards. So it's definitely something that needs to be addressed. And I think something we really find with our members is that actually the skill involved in producing really straightforward information is not recognised by large swathes of the healthcare professional community. So people think that anybody can write an information resource and that it can be tacked onto anybody's job as just the last thing to do, or that a clinician's really really good at doing it. And I think actually something that PIF really tries to champion is actually there's some really real skills involved in doing this well, and so it's championing that, but it's also we do training and stuff to help people develop those skills. So.
And coming on from that, we've had two questions around more doctors and healthcare professionals. So firstly, one question we got slightly earlier from Polly was that many patients with rare conditions pick up psychological diagnoses before they get their actual diagnosis. So how can we apply health literacy, I think, here in the healthcare professionals to debunk those incorrect early diagnoses?
Okay. Well, I'm a GP, so shall I deal with that one on behalf of my profession? Okay. So there are two issues here. There's the actual sort of clinical knowledge and clinical skills aspect of it, and then there's the health literacy aspect of it. How do you take your clinical knowledge and clinical skills and communicate with the patients and the families in ways that are health literate? There are those two things. So all doctors, nurses, any registered health professional has a responsibility to keep their clinical knowledge and skills up to date. And so I think that's just a general responsibility, and the General Medical Council, General Nursing Council, etc., oversee that process. And the issue of whether one makes the right diagnosis the first time, that falls under, or even the second time, or even the third time, that falls under clinical acumen. All I would say is that if you're talking about rare conditions, we just need to remember that with rare conditions, GPs will only ever see one of a particular rare condition in their career. So I just think that needs to be borne in mind. And then obviously, if people haven't made the right diagnosis straight off, then that needs to be fed back to clinicians, and they need to learn from it. The other issue then is how you take complex concepts and communicate them effectively. And to build skills in that area, I think we need to be in discussions with the universities, the medical nursing physiotherapy schools, etc., so that people come out of their training with those health literacy skills. And then I think we need to include it in postgraduate training so that people then maintain and develop those skills as required. And obviously it depends what job you do. But if, like me, you're a general practitioner, actually those are skills that I use 20, 30 times every day. So my skills in those areas, I'm not expected to know everything about everything because I'm a GP, but I am expected to be able to communicate effectively with the people I serve. And so, for medical specialties like general practice, I think it should be a core competency.
Just take a slightly different tack on the question, which might be around how do you, so say you've produced a particular resource which might help overcome some of those myths or challenge some of those myths. How do you encourage health information professionals to use it and hand it out to their patients? And I think we found that working with healthcare professionals, clinicians, when you're developing information resources, really helps build up those links, and they then see the value of them, and they're much more likely to use them in their work.
And then we've just had 2 points of clarification for you as well, Claire. One question was, does PIF operate in Wales?
Yes, we do. Yeah, we've got members in Wales, and actually we've worked with some Welsh health boards to look at developing information strategies and stuff. So we do work in Wales.
Okay, great. And the second question was, could you say slightly more about your 10 tips for co-production that was mentioned on one of your slides about involving users?
That's not actually my 10 tips. It's produced by an organisation called TLAP, which is Think Local, Act Personal, and it's a really useful resource, which I'm not going to claim it's mine because it's not, but it's one of the resources we link to from within our toolkit, because it breaks down co-production really simply, and it's in sort of a 10-sentence description. So I'd go and look it up. TLAP, it's good.
Okay, great. So I believe we have had all the questions we've received, and I've noticed quite a few people have been dropping out. So if there aren't any final burning questions, I'll give you some moments to write that. But in the meantime, I'd just like to thank all of our speakers once again for joining us. It's been absolutely lovely to have you with us for our first webinar, and I'd just like to share a couple of upcoming events that we have at Find a Cure. So as I mentioned, we're doing a series of webinars, and our next one will be our website development explained, which will delve into how you can set up a website on a budget and develop content for it, hopefully building on the health literacy of today. And we've also got a free event happening in Birmingham's Children's Hospital next Saturday that's going to be highlighting some great examples of collaborations in the rare disease world. So everyone is welcome to come along to that as well. These links will be shared following the webinar. Let me just see if there are any questions. No, we've just had a lot more people thanking us for the webinar and thanking the speakers. So again, Claire and Jill, thank you so much. And thank you to everyone who's joined today. I'll be sharing the slides shortly afterwards. Thank you, everyone.
And Flora, thank you so much from me as well. It's been terrific. I've really enjoyed it.
Yeah,
thank you very much.
Everybody.
Okay, well, I will draw the webinar to a close. Thank you, everyone, for joining. Bye-bye.